Good afternoon, ANAC, Washington, D.C. Hello. Thank you for your patience as we sorted out our next speaker's presentation. Just one note of housekeeping that Rashida Chandler's presentation tomorrow at 12:45 will not be held here, but rather will be featured as a national webinar in the future because Dr. Chandler is unable to be with us. So that's unfortunate, but look forward to it in the future. And now it is my honor to introduce Harold Phillips, the Director of the White House Office of National AIDS Policy. He's leading this administration's domestic HIV priorities and monitoring the implementation of the National HIV/AIDS Strategy, coordinating across the administration to ensure that America's response to the HIV epidemic is accelerated, comprehensive, and most importantly, reflective of the lived experiences of those at risk of and living with HIV. He has extensive experience at the national level in responding to the HIV epidemic across bureaus and institutions and working with nurses all along the way. I encourage you to review his bio in the conference website. And now please join me in welcoming him to the podium.
Thank you. Good afternoon and welcome to Washington, D.C. Yes, it's fantastic after so long to see people in person here at one of our conference venues and seeing a lot of my terrific nursing friends and colleagues. And I just want to, before I start talking sort of about the official stuff, I just want to thank all of you and those of you all that are in teaching as well as providing care and treatment for taking care of us folks living with HIV throughout all of this. It's been a scary time, a time where there was a lack of information, a time of fear and uncertainty. And to be quite honest, our healthcare professionals were on the front line still trying to figure out how to make it all work. So from the bottom of my heart as a person living with HIV and also on behalf of the White House, thank you so much for doing what you do and for just helping us all get through it. I don't think we say that enough to our frontline professionals. So I think this button, nope, that is not the button. Is that the button? No, it's the big green button, goofus. Okay, so it's the big green button. Okay, so I'm gonna talk with you all a little bit about several things, both an update on the Office of National AIDS Policy, which President Biden reconstituted, I call it, so he added water and added me to that office, which had been dissolved under the previous administration. And as I talk about some of the administration's HIV priorities, I hope that you all also begin to sort of see the importance of that office and why there's a need to continue to support a White House Office of National AIDS Policy. And one of the first tasks that I was given, in addition to sort of helping figure out what the administration's HIV priorities are, also think about revising and updating the National HIV/AIDS Strategy and going back to having a National HIV/AIDS Strategy rather than an HIV plan. And a strategy including the entirety of the federal government and all sectors of American society to help us reach our goal of ending the HIV epidemic by the year 2030. And oh yeah, Harold, do that in the context of COVID-19, partially from your dining room and partially from the White House. So that's been the challenge of almost the past 6 months. But what I'm gonna share with you all, and you all are one of the earlier groups that I'm sharing this with, we are on track to have a new national HIV/AIDS strategy by World AIDS Day. Yes. that includes input from the community, our federal partners, ANAC, and others who have sort of said, these are the things we want to see in this strategy. So I'm going to walk you through that. But before I do that, I just want to share some of what you all probably already know, but some of this data also is the 2019 data. So you may not have seen it when I get to that. So of course, like I talked about, sort of reconstituting the office, that all took place in early June as part of the 40th anniversary commemoration. So that morning of the 40th anniversary commemoration was quite a moment in my household and also among my parents, because that was when the White House wanted to announce my selection and that the office was back. And then, of course, that was on a Saturday, and then, of course, it was, and Harold come to the office on Monday. But as part of that 40th, really and truly both beginning to reflect and recommit the United States to ending the HIV epidemic, re-energizing our efforts, and also figuring out how to re-engage, recognizing that both we're still dealing with COVID-19, but the goal of ending the HIV epidemic by 2030, we needed to begin to figure out how to pivot and continue the support that we needed. So in terms of overall, again, this is probably the stuff that you all already know. In terms of our new infections on an annual basis, 34,800. Without additional intervention, we have nearly 400,000 new HIV infections by the year 2030, and that we're still not where we need to be in the United States when it comes to viral suppression. This slide, which is the 2019 data from CDC, you may or may not have seen it. Some hopeful signs of progress as well when we think about new HIV infections, which fell from the years 2015 to 2019. And it also shows at the bottom where our national HIV strategy is. So while we have some hopeful signs of progress, we still have a long way to go. And when President Biden has talked about ending the HIV epidemic, and also his funding request for this year, which is still not approved, he talks about accelerating and strengthening our effort. And this slide, I think, is a good example of why we need to do that. But within looking at sort of the overall hopeful progress, when you begin to drill down, and this is the importance of what epidemiologists call stratified data, you begin to see what it looks like in terms of hopeful signs of progress. And I'll start with 1, 2, 3. The third group of bars that are there, white, gay, and bisexual men, where you see the largest decrease in new HIV infections during this period. So our hopeful signs of progress are really among that key priority population, which is really great. But when you look at African American, gay, and bisexual men, which is that first bar, you don't see very much drop off between 2015 and 2019. Same thing for Latinx, gay, and bisexual men. Then when you jump over one and you look at African American heterosexual women, you also see we don't have much progress. When you look at people who inject drugs, it's the group that we're going the wrong direction. And some of this is about the opioid crisis. Some of this is also the increase in stimulant use, such as crystal meth. Some of it is also many of our syringe services and harm reduction programs are under attack. So I forgot to say, in my official role to educate you all, because I'm, according to federal rules, not supposed to encourage you to advocate. So there may be some education about some particular policy issues that are of interest to nurses that I might mention and highlight during this speech. So please take note. Harm reduction works. Our Office of National Drug Control Policy within the White House, for the first time, is including syringe services programs as part of their strategy, which will be released in early 2020. We also, for the first time in ages, have SAMHSA paying attention to harm reduction programs that include syringe services programs. There's additional funding through this as well. In the American Rescue Plan, federal funds can be used for syringe services. And I think the last version of the congressional language did not sort of include the language about the ban on the federal level as well. But we need to continue to educate and make sure that individuals, especially those in decision-making positions, understand that it's not just about handing someone a needle. It's really about entry into care and prevention and treatment services. And really, when we think about sort of the misinformation around these programs, we really need to begin to combat that, because when we look at our priority populations, this is the one that's going in the wrong direction of all of them. So while we've got hopeful progress and we've got slight progress that needs to be accelerated, we have one group in particular where we're going the wrong direction. And so we need to give that some more time and attention. Okay, so this slide, I won't spend too much time. Actually, I would think I was gonna take this slide out because CDC today told me it's not correct. Anyway, so we're gonna take this slide out, but again, the importance of stratified data to look at this all by race and ethnicity is really important. The other thing that I would say about the National HIV Strategy is it is currently going through departmental approval processes, and so even as late as 2 hours ago, I was getting no, you need to change that. No, this needs to be fixed. You know what? CDC has some more data that's more recent and updated than that previous slide, so that should go in there too. So again, so that's why that slide should have come out, but I sent it to Carol and Aaron on Wednesday like I was supposed to. Anyway, prevalence-based HIV care continuum, which you all know, we still have a lot more work to do when it comes to raising the bars. The bars are not where they should be, and this is the 2019 prevalence-based continuum from CDC. Another slide that I want to just show data-wise, sort of what's happening nationally that we should pay attention to. Oh, well, it won't do it. Yeah. So the gold bar there. This is our 25 to 34-year-olds. Nationwide HIV incidence. The purple one, which starts here at the top, is our 13 to 24-year-olds. So the good news is incidence, which is our estimate, is going down among young people. And there are a lot of different societal factors that are playing a role in that, according to talking to CDC. And so again, this is estimated HIV incidence levels. Some of it is some young people, I won't say all, some young people are delaying sort of the onset of sexual debut. Some of it is the internet. Some of it is other things that may be happening in society that may be causing that drop. We are still concerned about our young people. We are still concerned because while HIV incidence may be decreasing among young people, we are still seeing a large number of STIs in young people. And so we really need to continue to pay attention to this, which is why we've kept them as a priority population. The other thing, let's see if I can do that magic again. Okay, so the 25 to 34-year-olds, we more than doubled in terms of our estimated incidence. And what I said to CDC that we've got to think about as we move toward implementation is somehow some of this group might be getting infected later in their 20s, or sort of like that 23, 24, but also our messaging and our programming and our approach. Because I know personally, when I was 25 and had some disposable income, I was playing and working in different spaces than I was when I was at 22 and could barely afford lunch. So what does that mean for national programming and policy? And this includes all groups. So how are we really reaching our young adults with HIV prevention messages? And I think about some of the conversations you've had over the course of the conference about women in PrEP. Where are they getting those messages? Where are they getting that awareness? Where are they getting that? Even young gay men or young adults gay men at 25 to 34. Where are we reaching them? So while we have some success, we have some things we really need to be thinking about when it comes to incidents. The prevention and treatment toolkit, as many have said, we have everything we need to be able to end the HIV epidemic now. And there's a lot of excitement about injectables and implantables and how will that make it. I'm hearing people who are getting on sort of the 1 month injectable and really excited about not having to worry about a pill every day and what that might mean for them and adherence and U equals U. So not only do we currently have everything we need, there's more coming. So when people are asking me, Harold, are you serious about ending the epidemic by 2030? You bet. You bet I am. But we've got to figure out how do we increase access and awareness of these tools to be able to do this. And that's part of the challenge. The status neutral HIV prevention model here, which many who are from the New York area might be familiar with. Dimitri, who is at CDC, thank God, and doing some amazing work with them, has brought this not only to CDC in Atlanta, but also as part of the National HIV/AIDS strategy. So we are going to continue to push status neutral HIV prevention and care. So again, another piece that somebody might want to take note of in case we need to educate some folks about the importance of scaling up HIV testing and using this model to move us forward toward ending the HIV epidemic. Okay, the administration's priorities. Now I get to go through the good stuff. So I've already talked about the need to accelerate our efforts, and you can see by the data why that's so important and why President Biden, in his budget request, talked about the need to accelerate and strengthen the effort. Equity. From day one in the administration, the executive order on equity has been front and center in all of the administration's work and thinking about it, and an equity approach from being people-centered. And how do we go about our work and think about the populations and geographic regions that have previously been left behind in our policy and in our programming, in our approach, and how do we erase that gap? Eliminating HIV stigma, discrimination, and HIV criminalization, another important and key factor. President Biden talked about this on the campaign trail, and I have been reminding people that he did talk about that. So part of what we will be looking at, and it's not only included in the strategy, but also starting next year, how do we begin to support states in eliminating HIV criminalization laws? Access to health care, the role of the ACA, Medicaid, Medicare programs as well, and their work in this too. And the social determinants of health and their impact. It's fantastic, I think, to be doing this work at a point where there's a greater understanding of the impact of social determinants of health. And people are actually asking the question, so what can we do about it? And how can we use the power of public health to create new partnerships and new collaborations that help us in this way? Creating the social, physical, and economic environments to promote and attaining good health and wellness, as well as continuing the syndemic approach. So looking at the intersection of HIV, STIs, viral hepatitis, substance use, and mental health disorders as well. And then behavioral health as an administration priority. One of the other pieces that I've had to do is figure out from the ONAP perch, some of these things happen not only HIV specific within the administration, but how do I work to help ensure that there's an understanding of these issues and their impact and their programs on individuals at risk for HIV infection as well as those living with HIV. And so a lot of the things that are happening within the administration, some of them I'm sort of going, oh yes, and that's helpful for us. Oh yes, do that transportation thing because our clients use public transportation to go to clinic visits, to go to the doctor, to go to the public health department. They're on the buses, they're on the subways. Yes, fix that. So it's those kinds of things. Oh, we have broadband internet? Oh yeah, there's poor broadband internet in Puerto Rico. You can never get the health data you want if you don't have solid internet. So it's those conversations that are happening and I'm encouraging them like, yes, that would be super helpful. Do that fast, help us to end the epidemic by 2030, of course. So then there's also COVID-19. And you've seen some of this already. HRSA just recently revised 6-month recertification, and their eligibility requirements for Ryan White services, making it easier because some of the assumptions that we had prior to COVID-19 realized, oh yeah, we don't necessarily need that, or we can do without it. Now they were working on it and thinking about it, but I think this helped accelerate some of that. We're also looking at what else have we learned or we've done and put in place that is really helpful. So telehealth, HIV self-testing is another example of something that's been implemented. Multi-month prescriptions, also terrific. And so what are those innovations that we need to sustain moving forward that would be helpful to our HIV response? And then engaging and expanding the role of the private sector. And by that, I'm not just talking about pharma, which we love, spending pharma money. But at the same time, there are other private sector partners who, when asked, are willing to help. Walgreens is willing to help. Apple is thinking about HIV in new and different ways. So the technology sector, our commercial sectors, bringing them all to the table around this national goal of ending the HIV epidemic by 2030 and using the White House to be able to do that. So again, it's been about new partnerships, more collaboration, and I've been really excited by some of the other federal departments that we have brought to the table to help them explain to them why this is important, what we're doing, and what we might need them to do. So it's exciting to have not just HOPWA at the table as part of HUD, but also folks that are in charge of Section 8 and rental assistance, and have them understand these issues and go, oh yeah, we might be able to do something. Would like HIV awareness in public housing be helpful? And I almost wanted to cry and go, yeah, please do that. So we've got them all at the table. They're all really sort of bought in, and it's great and been wonderful to see. The other thing I would say is faith and community-based organizations, also working with them, more involvement from our educational sector. So we've got the Department of Ed at the table too. And then, so a lot of those sort of pieces really working toward them. The other thing that I talked about with Carol in the hallway was engaging other sectors as part of the HIV response. I think over the last 2 years and in my previous position with the Office of the Assistant Secretary at HHS, we really engaged the pharmacists over the last 2 years. And so OIDP, the Office of Infectious Disease Policy, because I left them, but I checked on them yesterday, and they said, yes, nurses are the next sector that they really want to sort of hit hard in terms of engaging and bringing in, and also oral health providers. So, yeah, so I think, you know, as we start to do this, and I'm not turning my back on the pharmacists, I'm still gonna keep that, but we're gonna put a big emphasis on both nurses and the oral health sector moving forward over the next couple of years as well, and working with the associations and with the schools. So we'll be doing much more of that, and you'll hear more loudly on those pieces. I already talked about some of the other administration initiatives that are gonna help us, and keeping an eye on those and what they mean, and ensuring that they understand the connection between our communities and the work that they do. So those are also listed here too. And I think I covered those all. Don't forget open enrollment, and this link also includes the link to how you can become a champion for coverage. So I really encourage you all to help us do that. One of the best things to happen for us is Medicaid expansion and the ACA. And I always sort of point out to that. And we're continuing to figure out different ways to make that work for our communities, both at risk and living with HIV. Okay, EHE, I think I pretty much almost covered this, except the $670 million request from Congress, from the president. It's still a central focus, and also that moving quickly and that accelerates. So hopefully by December 3rd, we will get a budget and we will get that. This $670 million is an over $200 million increase from the previous EHE allocation. So it's really important that we get past a budget for this year that includes full funding that meets the president's request. So fingers are crossed that that happens, but Congress needs to do their piece. Did you get that, Carol? Okay, all right. We're still keeping the same goal, 75% reduction by 2025. We talk a lot about 2030, but 2025 is a key and important year. We gotta scale up access to PrEP. We gotta scale up treatment. We gotta eliminate barriers to treatment so that we get that 75% reduction that will enable us to get to the 90% reduction by 2030. So I gotta get a bunch of folks undetectable, a bunch of folks who are not in care into care. I gotta reduce new transmissions by scaling up PrEP and PAP. If that happens, then that starts bringing things in the right direction. And that's why that 2025 piece that you don't hear a lot about is really important. So again, as President Biden said, accelerate, and I've talked with members of the Domestic Policy Council about the need to accelerate. That's not a joke. If we're gonna do this, 2025 is key. Again, also focusing on those geographic areas of the country are important. And so here's something else that I'll sort of talk about as well. EHE, and I'm gonna reframe this for everybody, and not everybody's sort of heard this reframing. EHE, Ending the HIV Epidemic, the initiative, is an equity intervention. The initiative is an equity intervention because it focuses additional funding and additional attention to the areas of the country that are contributing to more than 50% of the new HIV infections. It's an equity intervention because when you run the model out to 2030 and say, if you used effectively every dime of public and private funding for HIV, you end the HIV epidemic everywhere in the country, except for these 7 rural states and these 48 counties in the United States. They would have a disparity. That's why EHE is an equity intervention, and nobody's ever told you. That's why we have to continue that focus on these geographic areas and the populations in those geographic areas where the disparities exist. Now, having said that, and this is another one for Carol's pen, not only do we need to fully fund EHE so that we can reach those targets, we also need to ensure that there is adequate funding for the rest of the country to continue the core HIV prevention and treatment work. Because if we take our eye off that ball and they're not getting funds and because they're continuing to find folks and get them into treatment, get them into care, scale up PrEP. And they need funding to do that. And they might want to find ways to do it more effectively, like nurse-initiated PrEP. But to do that, they need additional funding. So we need to fully fund Ryan White, CDC prevention activities, SAMHSA, as well as EHE, which is our equity intervention. Okay? Again, those 4 pillars in that framework are really important about diagnose, treat, prevent, and respond. Those 4 pillars of public health are so important. And somebody said it to me, and I remember it, and I was like, oh my God. They said, Harold, with that framework, if you cannot end the HIV epidemic, what hope does public health have? It's up to the HIV community to show us how it's done. So use that framework, use the time and attention, show the world how it's done, and then let's do maternal and child health. Let's do environmental cancers. Let's do some of the other public health problems that folks have thought are intractable for years. And she said, you gotta do it. You gotta figure out how to get the country to make this work. Because when you look at diagnose, treat, prevent, and respond, that's the framework that public health has to use going forward. All right, the National HIV Strategy, and how does all of this fit together? Okay, so we're building on what the previous work done. We're returning to an NHOS, so we can use those words again, and this one will span from 2022 to 2025. Again, highlighting the importance of the year 2025 and the 75% reduction that we need by 2025. All right, embedded in all of that is the priorities that I talked about, as well as the most recent research data and findings, including research and data that comes from 2 hours ago. So and the engagement of additional federal departments and programs as well. This new edition includes input from 6 federal departments, 12 agencies and offices that have all been in meetings with me over the last 6 months, giving input and understanding the issues where we're trying to go and how they can contribute to the plan. It also includes recommendations from many community stakeholders. Some of the national AIDS organizations all got together, took input, did listening sessions, prioritized it, and then sent it to me to begin to think about how it gets included. Now we're working our way through review of federal departments. Hopefully Monday or Tuesday, it's going to Ambassador Rice for her to look at and say, yes, great job, Harold, keep it moving. And then final graphic design and layout, and then it will be available by World AIDS Day on hiv.gov as well as the White House website. Things you're gonna see in it from all of that input and also sort of thinking and strategizing and also based on what the data tells us, an increased focus on substance use, behavioral health, harm reduction approaches, greater emphasis on strategies focusing on people aging with HIV. You're welcome. And this is one of those where I feel like we heard from the community, and as the feds sat back and thought, what can we do about it? How do we incorporate this? So thank you all for bringing that forward. The other thing that I'll point out that is sort of community input is quality of life for people with HIV. Wow. See, I got a cheering gallery right here in front. And for this, a couple things that I will say about this. And I think I talk about this at some point. The quality of life piece. So not only do we talk about it within the plan, but quality of life and what we've heard from the community is so layered, and it's layered beyond just sort of the lab values or medication adherence. We felt like in 6 months, we're not sure what national data sets we have that would be really important to help us measure our progress on it. Because everything within the plan that we've got in terms of our four goals, we've also attached indicators where we can measure where we are at baseline and then our progress as we move toward 2025. So what we wanna do is the feds are gonna come together, figure out what data sets do we have that contribute to quality of life, or could we sort of say this combination will be our quality of life indicator as part of this measure. We then wanna come back to the community and say, okay, it looks like this for us. Are we on track? Does this make sense? Is this enough? And then when we get agreement, then we're gonna establish what is that baseline, and then how do we measure our progress moving forward? So quality of life is embedded in there. We talk about its importance, what it is, and all the rest of it. Then we need to figure out January, hopefully I think we can do this in 3 months, but maybe I might give them as much as till May, to figure out how do we measure it. And I've also said it's important to work with the community in figuring out how we measure it. So that's where we are on quality of life. And then strengthening our focus on research. The last HIV plan didn't talk about research, even though the fact that we're sitting in this room all vaccinated is a result of the HIV research that has been done for years. And right now, our HIV researchers are learning a lot sort of working on COVID. So the importance of still moving toward a cure for HIV and a vaccine is also embedded within this version of the plan too, as part of the move to end the HIV epidemic. Beginning in early 2022, we'll be working with our federal partners to develop implementation plans. So one important thing about the National HIV Strategy is it includes a vision, it includes goals, and it includes objectives and strategies to end the HIV epidemic. But the specific activities which require money, the agencies are going to let us know how they plan to use their budgets to implement activities that align with this strategy. And so we're giving them from January probably until the end of March to submit those activities so that we can continue to monitor those things that are being put in place. And so, again, Carol, where the rubber really meets the road, where we have the framework, it's so what are you all gonna do to move us forward? What activities are you all submitting as part of your implementation plan? And how do you see us moving in alignment with this framework? So the White House and the federal government has said quality of life is important. What does that look like? What are you gonna do? I almost said what y'all gonna do, see? But so And that's coming to us in writing in January through March, but it is an opportunity to sort of influence what comes in those plans during that period as well. I think the other piece of this is also using ONAP, the Office of National AIDS Policy, to work with the public and, like I said, private sector partners as well, to get them to understand what we're doing and how they all sort of fit and buy in as well as our healthcare professionals and other stakeholders. I'm also, you all have probably heard that we have also added some new members to the President's AIDS Advisory Committee. I'm really excited about that. They're a more diverse group as well, and continuing to work with them so that we are looking at how do they continue to pull in information and the expertise of our communities and influence both HHS and the White House as we move forward. Some of the things that they are working on is they're looking at some of the issues around private sector engagement and what we can do around that piece. They're also looking at the issue of molecular surveillance. We know that the community, some in the community, have asked for a moratorium on the use of molecular surveillance. It's such a powerful tool, and I think we lose so much by sort of stopping its use. But I understand the community has concerns, and what PACHA has been trying to do, and you'll hear their meeting is on Monday as well, is look at some of those concerns and trying to figure out whether or not we at the federal government can address some of those concerns, and how do we address them to ensure that there is the data protection and privacy that's needed, but we still have access to this really important tool. So I talked about this, the vision, the 4 goals, priority populations, indicators of progress, our priority populations. So, yes, and I think I've talked about some of these already. So, priority populations, here listed on the slide, they are selected as priority populations because we have national data on incidence, diagnosis, and viral suppression for these groups. There are other groups that have large concerns, unique needs, but we do not have national data on them. And for some of them, do you really want me to have national data on them? So we've heard a lot about the need for sex workers to be included as a priority population in the plan. And so think about that. We've used national data prioritized on incidence, diagnosis, and viral suppression. At the clinic level, at the public health level, there's no one collecting national data on sex workers as a transmission category. Do you want me to start doing that? I think we need to have a larger conversation about what that means and what the implications of that are, while people are saying we want them as a priority population. At the same time, this new plan talks about the importance and the unique challenge of service delivery, both prevention and treatment for sex workers, and the need to ensure that our local response meets those needs. So we haven't ignored them, we have heard, but just let's think carefully about what it would mean to include them as a priority population. Also, it would take a lot of time to stand up those systems to be able to collect that data and information and to ensure that we have the right data and information. So again, I'm trying to end this by 2030, and so we talk about the unique needs within the plan itself. That's just sort of one example. There are other examples. The immigrant community is another one where we don't collect that data and information. And actually, to receive Ryan White services, it doesn't matter. You don't need to know. So I only want the federal government collecting data on stuff they really need to know. And so that's one. And I think so when we think about HIV prevention services in many public health settings, it also doesn't matter. So let's be clear and let's have some continued conversation and dialogue about how we collect and use information. And at the same time, note, we've still got some data privacy issues that we gotta address too within all of this that need to get done. All right, I talked about these, the other departments that are engaged. Also, another big success, the focus on the aging population, the community, the Administration on Community Living revised recently its guidance on the state of aging plans. Older adults identified as in greatest need now include LGBTQI+ populations. And the administration also supports technical assistance via its National Resource Center on LGBTQ+ aging. And for the first time ever, state plans will include plans to measure for each state how they will demonstrate their progress towards serving older adults living with HIV/AIDS. And that's a new element of their guidance. In addition, several other federal departments, HRSA, Veterans Affairs, NIH, are all working on focused projects to identify policy, programmatic, clinical, and research opportunities to expand and improve care for people aging with HIV. So I think we've at least turned the corner around sort of this issue. The feds have heard from the community and are working to begin to implement various aspects of trying to meet the needs. I have sometimes said that I feel like we're on sort of the precipice of a new change in sort of our healthcare system. Folks living with HIV really pushed years ago to get changes in how we approach like FDA approvals, how we approach access to care, community involvement, community engagement. And now, as folks are aging with HIV, I think we're gonna see a different change in our system as we try to figure out what are the wraparound services, how does our clinical services need to change to accommodate some of these needs as well. And so so it's exciting to think about what systems might look like in the future as a result of both our advocacy community as well as the feds embracing and knowing that we've got to do some things differently. All right, challenges and opportunities. Well, there's COVID-19, it's still around, but hopefully we are sort of getting to a better place. But I think as much as COVID has been both a challenge, there have been some innovations that have come out as well. So that embracing of telehealth, HIV self-testing, multi-month prescriptions as well. And COVID has also given me the opportunity to see that anything is possible. I just think about it. And I have done, Carol knows this, I've done work in the global setting on HIV, where in many cases, telehealth was a necessity in order to provide HIV prevention care and treatment to individuals. And in my role previously at HRSA, I would jump up and down about the need to do more telehealth and more telemedicine in this country. And everybody was like, no, my people won't be into that. Or no, not with our client population, Harold. We can't because of X, Y, and Z. And then sitting in my dining room, I was hearing stories of some clinics that set up a telehealth program during COVID within 4 hours. So COVID has shown me no is not an acceptable answer. Anything is possible. So that's where I am on COVID in terms of what we can do and what we need to do. I've talked about our funding priorities and the need to ensure that we are continuing to fund our base programs as well as the EHE initiative, the geographic focus, and then political will at the local level. How do we do this? And I think also for you all in this crowd, really thinking about sort of at the local level, your clinic and hospital administrative practices that might get in the way of all of this. And so how do we push for change and innovation? And we'll be looking into that. I talked about sort of increasing the opioid epidemic as well as the stimulant use, mistrust, misinformation regarding public health and government. I've never seen anything like this. The Surgeon General just recently put out a report on medical misinformation. I know that pre-COVID, back in February of 2020, just before everything locked down, I was at a meeting at Tuskegee University, the home of the infamous Tuskegee Syphilis Project. And the meeting was focused on medical mistrust and the Black community. Medical misinformation seems to be even greater than medical mistrust. And the two are related. And so when I'm talking about sort of private sector engagement, one of the private sectors that I want to get to is sort of the social media world. And what can they do to help us to ensure that accurate, correct information about HIV prevention, care, and treatment gets out there so that we can begin to sort of turn the tide on misinformation. There are tons of clinical issues that also could slow our progress. So again, a good place to sort of take note and help me and others figure out what we should be doing differently and how we should be approaching some of these issues at the clinic level. Because I think there is, and this is why I also feel like nurses are so important, because you are sort of right there, front line, at the clinic door, at the bedside, and you all see and understand what's happening in lots of different ways that people who are sitting around conference tables in Washington thinking about policy and programs don't really understand. So your voices are extremely important as we try to figure out how do we address some of these things that might slow our progress. Say that again for the people in the back. All right, the policy, the Education and Policy Committee is very important. So some of the things that nurses and nursing schools can do to help accelerate sort of our HIV response, and there she is, as I was talking about some of the challenges, or hearing some of the challenges in scaling up HIV testing in ERs. And I hear that there was a great presentation at one of the workshops about that. I want to explore this because, again, a perfect example of, on the federal level, we think, oh, this is what we're going to do. We're going to provide money to hospitals to scale up HIV testing in ERs. Okay, and we think money is the problem and they will want to do it. But as was shared in the workshop, there are additional challenges that we hadn't thought about, that we need to work to overcome. So again, sort of that engagement in both hospitals, hospital systems, and at the community to help ensure that there's a swift implementation of all this great implementation science that we're all sort of working on across the country. Sort of adapting to ensure that people aging with HIV can receive whole person care. So we talk about sort of quality of life in the strategy, but we also talk about whole person care as well, and how do we address that? And in thinking about whole person care, what's the role of the social determinants of health? Again, sort of that intersection that's really important. Increasing in the inclusion of paraprofessional teams and looking at the intersection of this endemic, and then expanding the uptake of data to care models. And also, what is our data telling us? I didn't bring it in and share it today because I'm still trying to figure out some of this and what is it telling me. We sort of looking at pharmacy data. So I think many of you all know that CDC surveillance data takes about 2 years before it all, like I showed you 2019 data, and I know you all know what year we're in. But that's the latest, most available data. As I said 2 hours ago, they called me and said, this needs to be corrected, and we're still talking about 2019 data. But pharmacy data is more, I'm trying to figure out how I get access to it and how I get into that window of what is the pharmacy data telling me. And so the pharmacists have told me, yes, we have claims data, and we can show you the prescription that was written, and then some of our data can show you who picked it up. And so during COVID-19, we can look at fewer prescriptions being sort of written. Some of them were multi-month. We can look at that and sort of tell you sort of what happened there. We can also tell you who didn't pick it up. And just on first glance, I can now see that yes, COVID-19 did set us back. And as I continue to dig, I'm gonna be able to look at just how close, but thinking about how we use data. Data, something 60 Minutes said that I haven't forgotten yet, is that data is going to become almost as valuable as gold in the future. And this takes us back to the whole issue of HIV criminalization. And that idea of data privacy that we used to have 20 years ago is gone. What we now need to focus on is data protection. How will my data be used? Just like we are protective of how my money is used and where my money goes, you need to be thinking the same way about data. And I'm sitting there, I'm watching 60 Minutes on a Sunday, I'm thinking, holy crap, HIV criminalization data, public health data, this is what we gotta be focused on. How does that data get used? And when I give up my data, how much of my rights am I giving up for when it gets used second and third down the line? So again, really thinking about data and ways we can use data differently and implement models and understand what's happening in our communities is also what we're trying to do. Rapid and same day treatment. And so There are nurses in this room who've been talking to me about nurse-initiated PrEP. There's a difference in different states based on scope of practices and all the rest of it, and whether a doctor needs to look at your chart or whether doctor really is looking at your charts or not, or signing off, all the rest of that. But I'm gonna spend some time trying to understand those issues. If we're going to scale up access to HIV prevention services, we need to make it as easy and simple as possible. I think we've got the tools that are easy as possible to do this, but we still have these antiquated systems that are in the way. And I think unlocking the ability for nurses to be able to provide PrEP, I would much rather talk to a nurse about my sexual habits than a doctor. Anyway, just because you do what you do in the way that you do it, with care and compassion, and it makes a difference. So I think being able to assess risk and go, yep, PrEP would be good for you, young man, is definitely within your wheelhouse. So let's figure out how do we adjust the scopes of practice to be able to do that. All right. Linkage to care, expanding the number and variety and diversity and distribution of our healthcare providers, and also training to understand the roles of trauma-informed care, cultural competency, stigma, discrimination, all the rest of that as well. So continuing our approach with equity, reducing stigma and discomfort about sexual health and making it routine part of healthcare. Sort of the conversation about risk and how many and where and all the rest of it, can we be done with that? If you're sexually active, yes, let's do an HIV test. You don't need to tell me how many. I don't need to know, because that's not relevant. You don't need to tell me where and how you're doing it. Just, are you sexually active or not? Yes or no, since the last time I saw you. Okay, then let's do an HIV test. Can we get to that point? So really trying to take the stigma, the discrimination out, and the discomfort, because sometimes you might not be comfortable hearing how many. So, also scaling up access to post-exposure prophylaxis. PEP. PEP is so difficult still in this country. When people need it on a Friday, on a Saturday, many of you are at home, and you deserve to be at home, but we've got a 72-hour window. So one of the things I'm really excited about is DC has started sort of a hotline where you can call and they connect you to a pharmacist where they can get you started, as well as make an appointment for you come Monday morning when you all are back at work. We need more systems and more approaches like that. Because when this happens and when that crisis occurs, there's usually nobody to call and nobody to reach. Before all of this shut down and I couldn't travel, I ran into at least 2 or 3 people who told me I knew about PEP, I couldn't get access, I couldn't get anybody to prescribe, and I seroconverted. It shouldn't be like that. So I'm all about not only scaling up access to PrEP, but also PEP, and we've got to figure out how to make these systems work, because it's another important tool. Syringe services programs, I have talked a lot about that, and also, so as we think about, and I heard about the workshop for on Black women in PrEP that was canceled. There will be a national webinar. I encourage you all to attend. We have a huge disparity here. Right now, our Title X clinics, which provide reproductive health services, mostly for Black and brown women, are retooling sort of how they approach it under this administration. HIV testing, linkage to care, are also covered under Title X services. We should not let them forget that as they look at retooling and changing their programs and revamping their programs. Also, it's a huge missed opportunity if they're not also thinking about PrEP as part of reproductive health services for women. Their services include conception and preconception services, which also should include HIV testing, STI testing, and PrEP. So they're part of this mix, this puzzle that we need to think about. So as we think about unlocking PrEP access for Black women, we need to also be thinking about Title X, not just our community health centers, okay? And then continuing, and the plan calls for this, and I didn't say this earlier, engaging at the community level, but also ensuring that we have people with lived experience as part of our response, both planning, service delivery, and research. So that's it. So that's what I've been doing. Oh, and I think do we have time for questions?
We're going to go a little over, so we have about 5 to 10 minutes for questions.
Okay, and I know that there are some mics set up in the room, so if you have questions, line up and I will try to answer them. Hi.
Hi, I'm Justin from Boston, and I have a question about criminalization. So as it relates to drug use, sex work, and people living with HIV, that seems like a really easy thing to change stigma. And even if somebody can't be a priority population because we can't collect that data, decriminalization of sex work, decriminalization of substance use, those are all things that could go a long way and sort of impacting the epidemic in those subpopulations. And so I'm wondering if this is part of the strategy that you didn't talk about, or if it's something that was left out.
Thanks for that question, Justin. The strategy does talk about decriminalization, HIV criminalization, and the need to work with states to address and eliminate HIV criminalization laws. There are, I would say, other parts of the Domestic Policy Council that are looking at, well, let me say this. I need to go back and read this, and we all should, when the Office of National Drug Control Policy releases their strategy about substance misuse and criminalization, and see what's in there. Because there have been conversations about decriminalizing it, and I don't know, I haven't been in the conversation to figure out where did they land with this. So I'm interested, like it sounds like you are, to see how that is addressed in the strategy itself. With decriminalization of sex work, I think, and with all of these, we run into the challenge of the federal government versus the state and local government. And just like we run into challenges about whether or not we can mandate vaccinations or mask wearing, we get into some of these situations as well. But with regard to HIV criminalization, what I am looking at is ways that we can support educators and policymakers and lawmakers around the criminalization issues, and continue from the federal level to talk about the stigma and discrimination that it sort of presents and supports, and how this gets in the way of our HIV goals. Yeah.
Hi, I'm Zyra Gordon-Smith, representing Chicago chapter.
My home, yes, my hometown, yes.
Yay,
Yeah.
Southside, okay.
Yes.
So my question has to do more with empowering nurses as well as advanced practice nurse. I'm an advanced practice nurse in Inglewood.
Yay.
Our hands are somewhat tied in regards to restrictive privileges and not being able to practice at our full strength in order to be able to not only combat HIV, but also our ability to prescribe Suboxone and be able to work with the opiate use. And one of the other things that I noted as a provider doing telehealth, even restrictions in regards to us being able to do that. So I know in your policy you alluded to some of those things, and we are ready, we're geared, we're prepared, we're trained to do that, but our hands are tied. And so whatever, you know, I just want to bring that up as something for us. How could the government facilitate that so that we can practice at our full scope of practice to be able to combat this?
Yep, thank you for that. And thank you for saying that you all are ready. One of the things that I've learned very quickly in the last 6 months is that when people say they want to help you, I have been learning how to say yes. Yeah, I need that help. And so I've talked a little bit with some in the audience about the need to look at some of these issues about sort of the scope of practice for nurses that are getting in the way of sort of our HIV goals, and how do we begin to sort of shape policy in a different direction. And that part of what I want to spend January through June doing is understanding these issues and the difference between one state and another, or how it's being implemented, and where are some of our best models, so that June through December of next year, and maybe by World AIDS Day, we'll be in a different place when it comes to nurses. Yeah.
Hey, so nice to see you. Carol Vincent, Philadelphia. I'm a nurse practitioner by background, and I work for the Focus program. I know you know that program. One of the things that you mentioned, and I am ever the optimist. I've been with these people for several decades, and if anything can get done, it'll be with people in this room. So you were right when you said, Carol, put your pen to paper, because she will lead us in this. But what I am concerned about is the acceleration of the plan, simply because we talk about the power of public health, and you mentioned that a couple times. Public health is strained beyond belief right now. There's so many cracks in it. And so the real infrastructure build really needs to be in public health and how that intersects with healthcare delivery. And so I'm just wondering how realistic we think it is to move the plan up 5 years. While I think it's a great idea, I'm worried about that and wondered what reassurance you might give me.
So I will say that thanks. There have been some investments made in public health, both through the American Rescue Plan, as well as some of the other pieces of legislation that are coming forward that invest in public health and our public health workforce. The other investment that's working its way through is the Data Modernization Initiative that looks at how do we modernize our public health data for interoperability, to be able to share between social service providers and clinic providers as well. I don't think we're done yet. I think part of what we're doing is playing catch up. The other thing that I didn't say about COVID-19 is it's really served as like one of those injectable dyes where we can sort of see weaknesses in the system. And the administration is definitely trying to respond to some of those. So I haven't given up hope yet. As Susan Rice has said to me, our job is to continue to move as quickly as possible and get as much done as we can under this administration. And not only repair cracks, but see where we can make some gains as well. So I haven't given up. I know there's there's some investment that has happened, but I don't think it's all of the investment at this point.
Great. Well, count on us, for sure.
Absolutely.
Hi.
Hi.
First, I'm Damon Jacobs. I'm a psychotherapist, New York-based. I've been spending the better part of the last 8 years helping people learn about PrEP, using social media to help people get access and resources to PrEP and PEP in their area. And similar to what you described, during the lockdown, many people were sharing with me their experiences of not having access to PEP and PrEP during the lockdown and seroconverting as a result. My question to you is, has there been any serious consideration about over-the-counter availability of PEP and PrEP? And if not, how do we start that dialogue?
Ooh. Ooh. Yeah, that's a really great question that I don't have an answer to. But my brain is saying,
Let's talk.
My brain is saying that might need to be a change in the FDA classification for it to be over the counter. And I don't know if that's the starting point or not, but they're key to that happening. I think it's a great idea. I mean, I'm putting all ideas on the table, and definitely we'll sort of look at that piece of it. And maybe it's the oral PrEP that could be, now I'm really thinking out loud. Maybe it's the oral that would be first, or it would have to be, because we couldn't get there with injectable and implantable. But oral PrEP, could we get to a point where it's over the counter, and what would that take? Okay, no, Absolutely. I'm going to make note. Thank you. Just a good one.
Hi,
Hi.
my name is Darcel Reyes. I am a professor at a university in New Jersey. And many years ago, we got a HRSA grant to start an HIV program for advanced practice nurses. And we produced some wonderful nurses, nurse practitioners doing great work as clinicians, and in their projects that they developed in that program, they changed practice and they improved practice for people with HIV. The school could not afford to keep the program open. I'm wondering if in the new strategy, there is some funding for us to have more advanced practice programs in our nursing schools to produce more nurse practitioners and nurses to be caring for people with HIV. Is there any grant funding that will be in the plan?
So thanks, and I'm with you. I love those programs. I was at HRSA as the director for that office with the AIDS Education and Training Centers, and the nurse practitioner programs did incredible work, and I know that many of those universities weren't able to continue it after the funding went away, and I think it's Duke and UCSF that continued that work. So the strategy itself is not a budget document, so it doesn't talk about funding and it's not connected to funding. But what it does is it gives us a framework and an ability to go to educate Congress about the need for funding for some of the priorities and the strategies that are in the document, as well as our federal partners and colleagues. So I have suggested to Sue that perhaps it's time, because it's been a number of years now that those programs went away, that it might be time to have a talk with our colleagues at HRSA, and not just the HIV/AIDS Bureau, but also the Bureau of Health Workforce at HRSA, about ways to continue some of this effort, because they did incredible work, and I'm really happy that at least some of them have been able to continue those programs.
Thank you.
Sure. Hi.
Hello. Thank you so much for coming. My name is Dr. Myra Rutland. I am an infectious disease program manager from Spectrum Health Services in Philadelphia. I'm a family nurse practitioner. I am very passionate about making sure that my colleagues embrace PrEP, and eventually I'm going to work with them about PEP. But I need to say that maybe there should be a way for us to bridge what specialists do with primary care. We're working very much in silos. What is the solution to get more people talking to primary care providers and letting them know it's easy? You should have this conversation just like you would checking someone's hemoglobin A1C. There's no way that you would assess their risk and not check a hemoglobin A1C. If I assess your risk by doing a sexual history, I should consider PrEP or PEP as a part of your medical regimen. Yep. So that's the first thing. And then in doing that, some of the abilities to get continuing education credits or to come to conferences like this. Not every clinic or setting allows providers to come at the cost of the clinic or setting. It may have to come out of their pocket. Those things were removed by the prior administration. I'm wondering if there's a way for those write-offs and those reliefs to be given to nurses again, because you can't even write off your uniform anymore. That was something that nurses could do, and now we cannot. Yep. So that needs to be revisited. And then finally, what about the good old public service announcement? Education is key. I spend much of my time with my patients educating them about whatever the issue is, why they should take their blood pressure medicine the way that I instruct, why that lipid medication is best at bedtime instead of during the day. And the same thing with PrEP and PEP. A public service announcement will be repetitious, and it's not offensive. It's meant to serve the public by educating them. Thank you.
Thank you. Thank you. Thank you. So I'm writing these two that have, actually three that have sort of stumped me, that I need to go back and follow up on. I had no idea about the tax changes, and now you couldn't include a write-up or write off your uniform. That's, so definitely we'll take a look at that. I think in terms of public awareness, that's also one of the things that I'm thinking about, the private sector and their role, and how in many cases, sort of their ability to communicate is much better than ours in government, and deliver these messages. So that's one that I am definitely interested in trying to figure out how we do more of that sort of broad-based education and awareness and getting the messages out around these services. There was another part to your question. So how do we continue the work to embed this in primary care settings? So I know right now under EHE, we're spending a lot of money going to community health centers to sort of embed HIV testing and access to PrEP into community health centers. Those that I think there were something like 290 health centers that previously had been dually funded with Ryan White money, so meaning they already had an HIV program. And in the first year of EHE, we funded those entities. So, which went pretty well for us because they were used to working with the community and the population, and not necessarily going to be horrible and awful and stigmatizing. This year, BIPIC is funding the health centers that did not have HIV programs. So the answer to how do we embed this into primary care settings, the story's not really written on that yet. I'm not sure how this is gonna go. You haven't been doing HIV for 30, 40 years, and now there's funding and you're gonna start this. So I think there will be some settings where this could happen easier and more sort of naturally, and they're ready, and they've been thinking about it well, and we're gonna have great outcomes there. There are some that are gonna need technical assistance, and then there's some where it's just not gonna work. So what's gonna work, and how do we have those conversations? I'm in this, okay, let's see how well this goes and how we do it. I have been told that clinicians tend to talk to and believe and trust other clinicians. So delivering the message needs to come from somebody else in that health cadre, not necessarily me, or not necessarily not to say that I can't do it, because I've also fought with some healthcare providers about perhaps you all been talking to each other too long and you need to start listening and talking to people living with HIV. So that's a whole nother sort of thing to sort of really understand all of this. But I think we need to continue to try to push for the conversation. I think there's gonna be some definite lessons learned that come out of this implementation with BIPIC that I'm curious to see. But I think it's on all of us to continue to try to have this conversation. Uh-oh.
Yeah.
Thank you. Thank you all. Thank you.
Thank you so much, Director Phillips, for your generosity and your time and listening to us, and hopefully the important messages that you all still have to share can be communicated via ANAC or other ways to Director Phillips. I just wanted to remind everybody there's a satellite dinner this evening, looking ahead, considerations today that may impact patients' long-term health, sponsored by Gilead, right here at 7:15. And there's a satellite breakfast at 7 a.m. in this room, reigniting urgency in HIV, the nurse's role in engaging patients across the HIV care continuum. So see you tonight, see you tomorrow, and have a good night, everybody.